Okay, welcome everybody to our afternoon session. We are going to be hearing from Jamie Ferguson on ICD-11, and Jamie is the co-chair of NCVHS's ICD-11 work group, as well as your day job as Vice President of Health IT Strategy and Policy at Kaiser Permanente. Yeah. So I'll turn things over to Jamie and be thinking about your questions for him, and we'll get a good discussion going after his remarks.
Thank you, and thank you all for having me here. I appreciate it. Nice to see some old friends here. Okay, so my name is Jamie Ferguson, as you just heard. I'm here to talk about the current status and progress that we've made on finding recommendations or finding information to support recommendations, I should say, for the potential adoption and implementation of ICD-11 in the U.S., both as a HIPAA code set and for other purposes. Now, and I'll mention this as I go through the slides, but I'm here talking about morbidity reporting only, not talking about mortality coding for cause of death or mortality reporting. That work is underway now. It's being done by the National Center for Health Statistics in the CDC, and so they're on a timeline for that implementation. So we're here talking about the potential study of ICD-11 for its adoption and implementation for morbidity use cases. Okay, let me I'll go through the slides, and then we'll see what questions y'all have, and I'll be happy to take a discussion. So a little bit about ICD-11. ICD-11 has been under development for over a decade, under development for over a decade before it was adopted by WHO in 2019. It became effective for implementation in January of 2022, last year, and that was when WHO offered a 5-year support period for implementation by member countries. I don't think we're going to make that timeline somehow. And we're here talking about the 3 primary components of use of ICD-11. So mortality, as I just mentioned. Now, using ICD for mortality reporting is actually a UN treaty obligation for the United States as a member of the World Health Organization. So we're doing that. And that's all done in the CDC by the National Center for Health Statistics. So hospitals don't do that. They have methods that bring out the cause of death and do that reporting. Now, in terms of morbidity use cases, there are a number of different use cases outside of HIPAA. So in terms of healthcare and public health, in terms of the potential use of ICD in medical records for public health reporting, for social and community health analysis and health equity reporting, for patient safety and for care quality reporting. All those different types of analyses are outside of the HIPAA use cases. And then, of course, we have the primary HIPAA use case in fee-for-service billing and payment as a HIPAA-mandated medical code set. So we're here talking about all of those things except mortality. So the committee, NCVHS, has some goals for U.S. implementation. Specifically, NCVHS has some statutory responsibilities for HIPAA standards, as well as its broader mandate to provide advice on health information policy for the U.S. So the committee was interested in avoiding some of the stops and starts and protracted timeline that characterize the transition from ICD-9 to ICD-10. We'd like to have some lessons learned from that, be able to do it better based on understanding the differences and how we could implement ICD-11 basically better. And we wanted to conduct research to be able to enable a smooth transition from 10 to 11, specifically for morbidity coding, as I said. And we wanted to understand, if we were to avoid a clinical modification, what would it take? So basically, clinical modification, as we have with ICD-10, is not a WHO ICD product. It's a product of the United States that's a separate code set that's published. It takes a lot of time, effort, resources, money, materials to produce that. And so if we were able to implement ICD-11 without a clinical modification, there would be substantial savings both in time and resources, not just upfront, but on an ongoing basis. We wouldn't need the entire apparatus for supporting our own coding system. So that's the reason for that analysis. And then we also wanted to identify what is it that the industry needs to understand for stakeholder engagement and preparation for a transition to ICD-11 so that we could have a good transition. We wanted to have not only a communications plan, but have an understanding of all the steps that would be involved. So before the current work group was established, NCVHS had several different things that happened. So the committee's been talking about this internally since, I think, 2018. In November 2019, the committee recommended that HHS evaluate the impact of different approaches to the transition and recommended to the secretary that the department needed to have leadership and needed to designate leadership for the transition to ICD-11. Of course, shortly after that, we had the public health emergency that came to the forefront, and I think, all other activities of this nature kind of fell back to the wayside. And so the committee picked this back up in September 2021, submitted another letter saying, in my words, no, we really mean it. You need to pay attention to ICD-11, conduct the research to evaluate these approaches. We outlined actually a full communications plan that was recommended, and said that this needed to have further attention. Which brings us back to the work group that I'm currently chairing. So it was approved in December of 2022. The committee voted to approve the formation or creation of a working group. So the function of the work group is to support the committee. The work group does not make recommendations or develop recommendations for the department or for the secretary. That's the role of the committee itself, the NCVHS committee. So, but the work group is free to do whatever analysis, research, create observations, findings, to provide all the information that the committee needs to make its recommendations. And obviously we wanted to have a broad reach and make sure that we got all the different perspectives from all the different kinds of stakeholders, not just payers, providers, vendors, but from nursing and research and public health and the academia, from many different perspectives. So we invited a range of members representing different wide range of stakeholder perspectives back in spring of this year. We've held regular workgroup meetings. We also were very fortunate to get resources from the department to conduct an environmental scan of all the research that's been conducted to date on ICD-11 and its implementation and adoption around the world. And it turns out, of course, most of the research is not done in the United States on ICD-11. The coding system has already been implemented in, I think, 28 countries. And so those other countries are the source of most of the research studies, but there are a number here in the U.S., some supported by ARC, for example, that focused on patient safety measures, things of that nature. So we issued an RFI. The RFI, due to a number of sort of conflicting deadlines and different factors, was delayed in its publication in the Federal Register, which only gave a short time period, really only a few weeks, for the public comment period. We did get responses, and I'll talk about that here. But the first RFI it was limited because of the time period limitation. You know, people didn't have enough time to really analyze and respond. So that we held an expert roundtable back in August 3rd was held. It was a hybrid affair, so both here at HHS as well as virtually. We had about 50 participants representing an extremely broad range of experts across the entire spectrum of healthcare, health data, and IT. And so we'll talk a little bit about the findings from that. We're about to report that summary of not only that meeting, but the entire first phase of the Workgroups activities. That report will be coming out in the NCVHS committee meeting in just a couple weeks here on November 30th. So look forward to that. We have all the content, I think, ready, but we're just kind of formatting that for the meeting. And then we were able to issue a second RFI that came out in the Federal Register on, I think, October 16th, which has a full 90-day comment period. So responses are due on January 12th. We're really looking forward to and hope everyone here has a chance to look at that and consider your answers to those questions and anything else that you want to say about ICD-11 for that RFI. And then we're also in the process of onboarding our new members so we're now in phase 2, we're in a new fiscal year. We have additional members. We identified that in the first phase of work of this work group, our membership was kind of heavy in certain areas of expertise and light in other areas, so we balanced it to make sure that we had full representation. Specifically, we've added expertise of practicing physicians, and we've also in primary care and elsewhere, and we've also added expertise in terms of system developers, vendors, and implementers. And so those are the areas that have been added for the phase 2. So regarding the requests for information, the first RFI, as I said, it was limited. We had those 18 responses. You can see the responses are on the committee website. They're there for you to read. But we were very excited and happy to be able to issue a second RFI and with a full 90-day comment period. And so this one asks a broader range of questions, actually, about content requirements. What content does the United States need in ICD-11? We ask more about burden reduction opportunities, and that's a theme that you'll hear, because one of the things about ICD-11 being a fully online modern digital system with lying on top of a semantic network is that it has great opportunities or greater potential for automation of everything from original clinical documentation, coding for reimbursement, public health reporting. All of these things can be far more automated with this modern online system than was done with the previous classification versions. And so we really want to hear about people's views on those burden reduction and automation opportunities. We also want to hear about governance. So how might this be governed? I think that in terms of ICD-11 being a product of the World Health Organization requires a different kind of relationship of the United States with the WHO compared to having our own coding system as a full CM that we have a full control over. And so that governance is important in terms of the role of private and public sector participants, but it's also different in terms of the governance participation because of the wider range of potential use cases for ICD-11 in terms of being used potentially in the EHR, in terms of its automation. And again, so because of that wider range of use cases, how do you represent all those different interests and stakeholder groups in the governance process? The impact on standards and systems. Obviously, ICD-11 is, just computationally and in terms of syntax, it looks different, and won't have a fixed field length because of post-coordination, which is one of the core features we'll talk about in ICD-11. And so how do the current standards and systems have to adapt, and what has to happen in order to update those? I think it's very clear. We will need basically a new generation of standards that would have to be adopted in order to implement. So that we want to hear views on that impact on standards and systems. And then, of course, in terms of workforce, this is a huge training opportunity, and and really can bring in a new, I almost want to say, a new generation of workforce, because it's opening things up completely. It's logically and technically different. And so just like with the change to online systems with the internet, this is there's I think a parallel there in terms of the changes in the workforce. And then what resource needs and how can you estimate those? So these are all things that we're asking in the RFI that's currently out for comment. I mentioned the August 3rd expert roundtable meeting, and so we we have information on that is also available on the NCVHS website. We got stakeholder input from many perspectives. It was just a one-day expert roundtable, and it was split between, we had some high-level presentations, for example, from the National Library of Medicine, where Dr. Kinhua Feng presented the research studies that they've done on different implementation approaches and the content coverage in ICD-11. And then we also had breakout groups, both in the morning and the afternoon. We split out into 10 or 11 different breakout groups so that we could have small group discussions on key questions that we'll talk about in just a minute. So right now, we've just concluded really the phase one of the work group. And as I said, the report on that will be presented at the full committee meeting coming up on November 30th. Specifically, we in the expert roundtable, what we asked people to focus on and discuss in the breakout groups was first identifying the adoption and implementation issues. What are the research questions that need to be answered? What is the information that's needed in order to support policy recommendations? And so, because we had the environmental scan of all the existing research, and everybody had a copy of that. And by the way, that's also up on the committee website for you to read. Knowing all the research that's been done, what else needs to be studied in order to make policy recommendations? And then secondly, can we develop a collaborative plan to maintain the momentum to finish these studies and assessments and to better coordinate them? Because what's happened, or what we saw that had happened over the past few years, is that there were, I don't want to say 1,000 points of light, but there were many different activities that were not centrally coordinated, I should say. And so, how can we better establish a community of interest for that coordination to gather the rest of the needed information? And then we also wanted to understand, what does it take to avoid a clinical modification? If a clinical modification is time-consuming and expensive, then what does it take to avoid that? And that was one of the key questions that we spent a lot of time discussing and have got a lot of information on. We also wanted to understand, what does it take to improve coordination of the U.S. with WHO, specifically and mostly around maintenance and updates to the coding system. So when the United States finds that we need a code, and if we're not in control the way we are with the CM, how do we get what we need quickly? How do what's the timeline? What's the process? How does that work? And then in terms of different collaborative approaches to coordinating the adoption and implementation. We discussed different opportunities or different possibilities for how it would all work together. Some of the themes that emerged from the roundtable. So first of all, I want to talk about, we identified a lot of potential benefits in terms of, particularly in terms of burden reduction, both for physicians, coders. A lot of coding will be automated. Huge potential burden reduction and resource improvement, I would say, in terms of public health reporting. If you consider a lot of the kinds of public health reporting challenges that we had during the pandemic and challenges that we have now with different public health jurisdictions requiring disparate kinds of data and making up their own requirements, I think the opportunities for doing that based on a new modern coding system would certainly improve the level of resource required for public health reporting. So what are the different automation advantages? And that includes the use of artificial intelligence, or AI. So how can AI help both in terms of clinical documentation, in terms of coding, in terms of reporting? And I should also say that, so we're only talking about this for morbidity analysis and morbidity coding and reporting, but in the NCVHS study of ICD-11 for mortality reporting, cause of death reporting, there's making extensive use of AI, and they're finding that AI is a potentially very valuable tool for identifying the cause of death and doing that reporting. So I think that there are opportunities there, and so again, it's just as we move forward with our digital health infrastructure, how does this fit into the picture? Well, then we also found some real potential challenges. We found that, no surprise, we don't have funding. So there's no current identified funding or funding source for ICD-11, and so coordinated governance and funding are going to be needed to conduct this work. And obviously, if through burden reduction and automation, if the long-term resource requirements are less, there's still a great hurdle to get over to do this implementation. I think I've mentioned this before, that the ICD-11 maintenance processes need to be well understood and managed well for the U.S. Obviously, that's a big area of focus. More content analysis is needed in order to assess different implementation approaches. So let me unpack that a little bit, because in order to achieve the kind of content that we currently are able to manage in our own product, ICD-10-CM, the NLM research has found that we're likely to have to do three different things at the same time. One is to create our own subset of ICD-11, which is called a linearization. The structure of ICD-11 is that the classification systems that you see and use are extracted or subsetted from an underlying semantic network. So we're going to need our own extract or linearization or subset, whatever you want to call it. But the current one that WHO publishes for mortality and morbidity statistics will not meet our needs for the same degree of content that we are able to have in 10CM. So we'll need our own subset. The second thing is that part of the syntax and the basic structure of ICD-11 is that it uses post-coordination. And so if you want left or right, or bilateral, then those are things that instead of having a new code that would say that, you append the code for laterality. And so appending that code to the body part or whatever it is post-coordination. And because of that post-coordination and the fact that you can you can append any number potentially of different codes together, you end up having essentially a variable field length, which can be challenging if your systems don't currently handle that. And you have to know sort of, what to be able to expect. What does that look like, and what is the syntax of it, and how will your system handle that? So we'll need our own subset. We'll need to use post-coordination, and that post-coordination, by the way, really is as a core feature of ICD-11. That's going to be used and that's going to be needed whether we had a CM or not. So that's not an artifact of a CM. And then the third thing is that after we have our own subset and after we do the post-coordination that we need, we are still going to have the ability to have a small number of, you can call them custom codes or optional codes, but there's going to still be a need for us to have a small number of optional extension codes that we would need for the US, and that also would be a part of the maintenance process where that might give us some of the flexibility that we need that we currently have with the CM. So all of those things together are how we could potentially achieve the full range of content that we want, not just matching 10 CM. I mean, if we're just matching 10 CM, then why change, right? But in fact, there are many things that would go beyond that, and so we would need to do those things, and so the balance of those different factors for achieving content will affect the implementation. So if we were to, for example, if we were to standardize the post-coordinated expressions that are used most frequently, then that could appear as if it were a pre-coordinated subset, just like the coding systems that we use today. But then that would have to be published by a standard, as a standard, and who would do that, and so there are challenges in there, and that has an impact on, of course, on our national implementation approach. So I went kind of deep on that one, but I think it's important to understand, and I'm happy to take any questions on that. So obviously, with these factors coming into play, the technical understanding of the costs and resources for these new challenges is not something that's well understood. And then another thing that came out in the expert roundtable is that one of the areas where there were really, I would say, divergent views presented is what's the role of ICD-11 in clinical documentation? Will this replace SNOMED? Will this, because of course, under the ONC regulations for certified EHRs, SNOMED is what's used for the problem set or diagnosis that is that's the interoperable coding system. And so if ICD-11 has the same degree of detail and flexibility that SNOMED has, will it live alongside SNOMED? Will it replace SNOMED? Or will we continue to use SNOMED for clinical documentation and then map to ICD-11? So that the role of that, I would say, is unsettled at this point in time, and it was great to have experts with strongly held and opposing views, and so there's a lot of study that we're going to have to do, and a lot of information to be gathered before the committee will be able to make its recommendations on that. And then finally, as I mentioned before, the education and workforce challenges, workforce changes could be profound. I mean, so a number with greater automation, some jobs are not needed any longer, but on the other hand, other jobs are going to be needed more, and they're going to be jobs with more advanced skill requirements, technically and logically. So there are those kinds of challenges. Okay, so what's coming up next? As I said, we're finalizing our workgroup findings report, and that'll come out in just a couple of short weeks here, November 30th. We are looking forward to, and we're planning for our analysis of the responses to the RFI that's currently out for comment. Really looking forward to that. We have a great plan for analyzing that after January 12th. And then, of course, after that analysis is complete, we'll report back to the full committee with those findings before we develop additional or new findings or analyses, discussion points, insights that we'll present back to the committee. So as I mentioned before, the work group is not charged with making the recommendations to the secretary, but is charged with providing the full committee with all the information that the committee needs to make recommendations. So that's what we're up to, and that's what's coming up in 2024. And so now, at this point, I think we've got time for Q&A. I'm very happy to take any questions. I see Stanley first. Let's get you a microphone so those online can hear.
Okay. Thank you, Jamie. That was very helpful to get an update on.
Yes, very, very complete. Thanks for the implementation steps that you talked about. The concerns that isn't mentioned is how this move to ICD-11 fits in with all of the other priorities and things that are going on in the healthcare system, whether we're talking about improving security or interoperability, things like that. So have you guys thought about that, where it fits into the roadmap, or is that not on your...
I'm very happy to say that question about how does this fit in with everything else is not in scope for the work group. However, I will say that some of the findings that we already have are that we believe that ICD-11 will improve interoperability, for example. Won't really do anything either way on security, which you mentioned, but does have a lot of potential to potentially improve interoperability in terms of how it will work with the other coding systems. So that is a factor. One factor that I would mention in terms of priorities, though, is that there is a lot of, I would say, heightened attention now to public and population health concerns. The causes and the factors that contribute to one's health and wellness, social, community, and public health. And in all of those areas, ICD-11 is far, far more detailed and more comprehensive than ICD-10 or 10CM. And so just as an example, so currently for the social determinants of health factors, 10CM has 10 codes. We've mapped that to ICD-11. In the same areas, ICD-11 has 150 codes that go far beyond that, and that analyze things that are necessary to understand and manage health equity. So a lot of analysis of health equity and programs on that basis would really benefit from ICD-11. Other areas where ICD-11 has significantly more content include, so there's a lot of concern about cause of injury, obviously, so that is a factor. I would say that in the mental, behavioral, and neurodevelopmental health areas, that's an area where ICD-11 has, again, just a far greater level of detail that's not present at all in 10CM. And I would also say that the studies that have been done, both in terms of clinical quality reporting, clinical quality measures in particular, so of interest to measure developers, measure developing organizations, both for clinical quality and for patient safety. The additional detail and flexibility in ICD-11 makes it appear that at least where it's been studied thus far, it is superior to 10 and 10CM.
We've got an online question.
Yes.
If you replace other code sets, will things like USCDI be backdated to reflect the changes? And what about fire resources that currently require other code sets?
Okay, so yeah, that's a sort of a standards version advancement process. question, I think that's probably best answered by ONC, but I would say that, just like in many other areas, you have to use mapping to create backward compatibility, so that would have to happen here as well. And there will be some cases where it will be imperfect. Mapping is always imperfect, and so the backward compatibility of the, changing from ICD-10 to ICD-11 will be imperfect.
Jamie, first of all, thank you so much for coming out from the West Coast to be here. I've got a variation on the first two questions. Is there any discussion within the work group about developing a roadmap or milestones? Because you mentioned that a lot of standards have to be changed to accommodate this new code set. We went through that, of course, with 5010 as the precursor to I-10. Is there any thought about doing that sort of roadmap? Because it will include things like quality measures as well that would have to be
Yes.
retrofitted.
Yes, thank you for the question, Rob. So yeah, absolutely. This is one of the recommendations that the committee has made to the secretary repeatedly, is that we need a roadmap and we need somebody in charge to create that. So, I don't think that the work group with our current charge to support recommendations of the committee is in the place to create that comprehensive roadmap. We'd need a new charge to do that. But obviously that is something that we're going to be talking about, because that's one of the things that we expect to, that is, your point exactly, did come back in the first RFI, and we expect to hear more on that in the second RFI. So whatever you think needs to be in that roadmap, please include that in your comments.
I wanted to add a comment when you were talking about some of the enhancements or changes in ICD-11 that are improvements. One area that I've heard about and have looked at is that ICD-10 categorizes gender identity and a diagnosis there in the behavioral health area, where in ICD-11 there is a new section, and now I'm blanking on what it's called, but it's moved into another section that has to do with sexuality and gender identity. So I know people with that community were very pleased to see those changes in ICD-11.
Thank you, Jamie, for all your work with the work group. It's been amazing, and I know very time intensive. But the question for you is, whenever I mention ICD-11, the first comment back is, let's just wait for ICD-12. Can you talk about how that is maybe not a good idea?
Well, you might wait forever, because the intention and the stated intent of WHO is that there will be no more versions after ICD-11. And we can say that because it is an evolving system that is specifically designed to be updated continuously and permanently. So, and this is, so it has this, as I mentioned, it's based on a semantic network that's updated continuously by semantic modelers and people who are, putting in the latest, whether it's a surgical technique or a new organism or a new finding. So that's all going into the semantic network. And then countries that implement the coding system extract from that or subset from that all the classification codes that they need. So the evolution of the underlying semantic network is ongoing and worldwide and in real time. So it's constantly being updated with the latest medical knowledge and the latest scientific knowledge. And so we would have to choose, if we have our own subset that we extract periodically, we have to choose when do we want to do an update and what do we want the parameters to be for that selection, for the selection criteria. But in terms of waiting for 12, there's probably not going to be a 12. Or if there is, it would be when the semantic technology changes, which might be 50 years or more.
So one of the things that you just mentioned there, and maybe you can clarify this, or maybe it's still an open question. Early on with the NCVHS discussions of ICD-11, there were comments made that because our ICD-10 procedure coding system, PCS, is really a misnomer because there is no ICD-10 procedure coding system at the WHO level, that the way ICD-10 PCS is built, it can accommodate changes and new procedures that come along. And so there were comments made very early on that we won't have to make any change to ICD-10 PCS. So we're only talking about the ICD-10 CM side of things and the diagnosis in terms of transitioning to ICD-11, but the PCS would stay the same.
That's correct. The ICD-10 PCS coding system is not a part of our work group discussions at all at this point.
Okay, so some people have said, well, that would have the work, and it's like, probably not have the workload from ICD-10, but it's something to sort of take off of the project scope.
Yes.
Back in the transition, the ICD-9 to ICD-10 is sort of higher level classification system, and things like it sounds like ICD-11 is a lot more detailed and a lot more like SNOMED than ICD-10 was, and is a different kind of coding system. May not, the uses that are for billing, for example, may not need the detail that it sounds like ICD-11 can provide. On that?
Yeah, I think that's correct. So for those who couldn't hear because of the microphone cutting in and out, Stanley Knockhamson just made a comment that it sounds like ICD-11 is perhaps more like SNOMED than ICD-10 because ICD-10 was seen as operating at a higher level of abstraction where SNOMED is at the most detailed level. And I think that's exactly right. That's true. So SNOMED is at the most detailed level. ICD-11 is, I would say, at a similar level. In some cases, maybe more, maybe less in terms of the level of detail. SNOMED still has the greatest number of unique concepts that are coded, but structurally, ICD-11 is like SNOMED in that it is based on a logical semantic network using semantic technology. And so where each concept has relationships potentially to multiple other things in a polyhierarchical system. So as opposed to the ICD-9, ICD-10, and previous versions that are in a unitary hierarchy. So you can't have something that's, if you have the difference between a unitary and a polyhierarchy would be if you have a cancer of the kidney, you can either have a disorder of the kidney or you can have a cancer, but you can't have both, because they would be in different hierarchies. Whereas in a polyhierarchical system, you express the relationship of those things, and that actually also is how you use post-coordination, is that you just append those different codes together so long as it models correctly. So it is structurally very different and much more similar to SNOMED. Okay, we are magically out of questions and out of time. So thank you.
Thank you, Jamie.